We're having few moments to start the case.
Okay, thank you.
Welcome.
والآرام में क्या कैसा सर्जरी की ड्यूटी देगा निसार से कनिष्ठा एग्जाम संग होतो नन्यो कना
Just please, when you finish, just please raise your hand because I muted all the colleagues. Okay, you are unmuted now, Dr. Azuz. If you can hear my voice, please just tell me.
Yeah, I can hear it.
Okay, you can go on, Doctor.
Hello.
Yes, hello.
My name is Dr. Ahmed, one of the doctors here. Am I talking to Mrs. Jacob Keth, 57 years old?
Yes, that's him.
So, how I can call you, please?
Yes, Jacob is okay.
So, Jacob, we're here today to talk about your problem, if that's okay with you.
Yes, it's okay with me.
Okay. So, during the consultation, I might take some notes, and this will just for the sake of the conversation, it will be confidential. Okay?
It's okay, doctor. Go on.
So, would you mind telling me about these disease belts? What do you mean by them? What do you have exactly?
Yes, doctor. You know, for the last 2 or 3 months, I'm feeling that I'm not myself. I started to have some, you know, some dizziness that I'm losing my consciousness. It didn't happen for me before. This was the last
Sorry
time.
to hear that.
Thank you, doctor. So it happens only for the last 3 months. That's
All
it.
right. So before the last month you were fine, and over the last month, how many times you lost the consciousness? How many times you blacked out?
2 times, doctor.
Sorry?
2 times.
2 times.
Yes.
And anyone was around?
No.
And can you remember what happened? What you were doing before that?
All what I'm remembering, the last time that I was walking around with my dog in the street.
Yeah.
And then after a while, I found myself on the ground. I don't know how, and my dog was making very was screaming, like screaming beside
Oh,
me.
yeah.
Um,
Yeah.
this is the first time. The second time, I was at my home, and also again my dog was beside me. I was watching TV, and then I found myself on the floor again.
Oh, that sounds scary, isn't it? So, and this, you said you lost the consciousness.
Yes.
Were you feeling any heart racing before that?
No, I did not.
Were you feeling that you are about to lose the consciousness?
No.
Okay. So, and you said in the 2 times you found yourself in the ground,
Yes.
did you find that you wet yourself? Sorry for this question.
No, doctor, I did not found myself like this.
Okay. And after the attack, were you able to like, what happened after that? Were you fine after that, or what happened exactly?
I was fine, yes, but I found,
Did you,
I found my tongue, the tip of my tongue, like some bleed. The tip of my
oh,
tongue.
so there was some blood there.
Yes.
And did you seek any medical advice for this? Did you see your GP, or you went to the A&E?
For the first time, I didn't seek any medical advice. I thought that maybe I slept only. I slept. Sorry, this is the second time. I thought that I slept, and then the first time also I thought that maybe I slept on the floor in the street. So I didn't go. But
And did you yeah,
when I was talking
sorry.
with my daughter, it's okay. When I was talking with my daughter, she insisted that I should come again. But what can I
Yeah,
remember in the last time? Yes, I feel, just remembered now, I feel some racing of my heart beats before it.
so just before that time. And did you sleep after these 2 attacks? Were you feeling tired and that you want to sleep?
No,
So this didn't happen for you.
no,
You were totally fine after the attacks.
yes,
Okay. And so did you suffer from any chest pain?
no, doctor, I did not.
Okay. Any shortness of breathing?
No,
And how many pillows do you use usually to sleep on?
one pillow only.
And you didn't increase the number of any of the pillows or anything like this?
No, I did not.
Okay. And do you have any headaches, or do you suffer from any headaches before?
Occasional headache, but not usually. Sometimes.
Not concerning you.
No, not concerning at all.
Okay. And after the attack, did you feel any weakness in any part of your body?
No,
Okay. And do you suffer from any pins and needles anywhere in the body?
no,
Okay. Any problem at all in the vision?
yes, doctor, I'm having problem in my vision because I am having diabetes, and I checked with my GB. He told me that I'm having some problems in my visions.
And so you are seeing the eye doctors for that one?
Yes, doctor, he referred me for this.
Any laser surgery done?
No laser surgery.
Okay. So is it under control?
I don't know, doctor. I am not a good
No
person
worries.
in following up, actually.
Oh. No worries, but I will check the records. I will find out. And do you have any problem in the ears?
Ear problems? No, doctor. Like
Yeah.
what? Like what?
Like any ear pain or any substance coming out from your ear, any material or anything?
No, no, no. Nothing.
Nothing like this.
Yes.
Okay. All right. Any sounds in the ear?
No.
Nothing. Okay. And what about your tummy? Any problem there?
No, doctor. I don't have any problem with my tummy.
Any feeling of sickness or throwing up?
No.
Any pain in the tummy?
No, doctor. I don't have pain in my tummy.
Any change in the bowel habits?
No.
What about your water work?
Water work is okay. I have no problem.
Okay. Any problem in any change the color of the urine of the water?
No, never.
Okay, great. And what about your joints and skin? Any problem there?
Joints and skin? No, no problem.
Any skin rash at all or joint pains?
No, doctor.
Okay. Have you suffered from any high temperatures?
Maybe 5 months ago, I had high fever, but I'm not sure if it's concerning or no.
5 months ago?
Yes, I received this oral paracetamol and everything went good.
And did you see your GP for that?
I didn't see my GB. My temperature was high a little bit. It was about 39, but you know, I read in the internet that things like this with fatigue, it may be a viral infection. So I took this paracetamol and everything was okay.
Okay. But at that time, were you suffering from anything apart from the fever?
No, doctor.
All right. And what about the weight? Any change in the weight?
Weight change? No. Apart from a little bit increase, but it's not that increase. Maybe 1 or 2 kilograms in my body weight only.
Okay. And what about your appetite? Any problem there?
No, doctor. My appetite is good.
Okay, that's great. So you told me you have diabetes. For how long you have it?
For the last 20 years.
And how usual is it? Is it controlled?
I told you, doctor, I'm not that good person that following himself up. I'm not good in this.
Do you know? Oh, and do you know your the last 3 months readings? You know this. We call it hemoglobin A1C. Do you know that reading?
Last 3 months, no, but I remember that 6 months ago, my GP told me that it was high and I have to be more serious in dealing with my condition.
And what kind of treatment do you take?
I'm taking insulin.
Do you know the dose?
Yes, doctor, I'm receiving insulin aspart, 3 units, 3 times per day, and glargine, 40 units once before sleeping.
Okay. And do you have any problem in the you told me there is no pins and needles for any problem like this?
No.
Apart from the eye problem,
Nothing.
there is no other problem. Okay. Do you have any other medical problem that I should be aware of? High blood pressure?
I don't have high blood pressure, doctor, no.
Did you have any heart attack?
Heart attack?
Yeah.
No, doctor. I didn't suffer any heart attack before.
That's great. Any stroke or mini stroke before?
No.
Okay, sounds good. And any problem in the calf, pain there while walking?
Occasionally, sometimes I feel this.
You told me you are active and going with your dog.
Yes.
Do you sometimes feel that your legs are painful and you have to stop walking?
It's sometimes become painful, but I don't stop walking. I continue walking actually.
Okay. And what about the health of the family?
Health of the family?
Yeah. Anyone having any diseases like any shakes, what we
No,
call it epilepsy? Anyone having something like this?
no, doctor.
Anyone died at young age
No,
suddenly?
no,
Anyone having any problem in the heart?
no, doctor. I cannot remember like that. I am an adopted person. I don't know if they are having or no. My mother and my
No
father. I don't know
worries.
this.
No worries. And with whom do you live, Mrs. Jacob?
I'm living with my daughter.
And is she taking care of you? Is she the main carer?
Yes, and her husband also living with us. 2 minutes remaining.
Oh. And do you smoke?
Yes, doctor, I'm smoking.
How many cigarettes per day?
20 cigarettes, doctor.
And have you ever thought about quitting smoking?
Never. I didn't think about this before.
I can help you with this. Actually, you have to consider this. And what about the alcohol? Do you drink alcohol?
Occasionally.
Okay. And apart from the insulin, do you take any other medications?
No, doctor.
Okay. And may I know what concerns you?
I'm concerned about this loss of consciousness, doctor. I'm very afraid because one of my friends I can remember, she was working with me in the same factory, and then all of a sudden they told her that you are having a bleed inside your brain. She had lost her consciousness, and they told her this. I'm afraid, doctor, I'm having the same condition or no?
I will just answer this in a couple of seconds. You told me you are working in factory.
No, I'm not working now. Now I'm not working. I'm retired.
Okay. And do you drive?
Me? Yes, I drive.
Yeah. Okay. So, Mrs. Keth, actually, from what you told me, it sounds like you had syncope. We call it syncope, and it might be from the heart, but again, it might be from the brain. And what we are going to do, I have to keep you in the hospital. I will run some blood tests. I will ask for some scans, and I might need to ask for just to raise your heart to know if there is any funny rhythms going there.
Time. Thank you. Okay.
Thanks.
Few moments for reflection. Okay, so what's your differential diagnosis, doctor, for this lady?
So this lady might have a cardiogenic syncope, but again, it might be like epilepsy. Actually, it doesn't sound, apart from the thing she said. She found that she was biting her tongue, and the problem that it was unwitnessed syncope. So I need a collateral history, actually. And collateral history, like someone was around to describe if she was having tonic-clonic seizures or what happened exactly. But again, is that she didn't sleep, like she was not having any post-ictal symptoms.
No post-ictal symptoms. Okay. So you think that either it is cardiac or epilepsy?
Yeah. It seems that her diabetes is not controlled. So this would also add to the risks of the cardiac problems.
Okay. Did you ask her about any previous hospital admission?
No, not.
Okay, blood transfusion. She had any blood transfusion?
No.
Any operations before or procedures done to her?
No.
Okay. So this patient is having any allergy for anything? Medication, drugs?
I think I did ask about the allergy, didn't I?
Allergy? Okay. Okay, doctor. So what is the difference between syncope and what is the difference between cardiac and non-cardiac syncope? How to differentiate between them?
So usually the cardiac syncope, the patient will have like palpitations before the attack most of the time, and then they will, if even they lost the consciousness, it will be for seconds, up to minutes, and they will not have any post-ictal symptoms, like they will recover directly. But like if we are thinking about neurological loss of consciousness or epilepsy, so it might be preceded by aura, and it might not. Then they will have tonic-clonic seizures. It might again not be there, and they will have tongue biting, and they might lose the control of the sphincters, and most characteristically they will have post-ictal state, so they will be drowsy or sleeping for maybe half an hour or something like this, 4 minutes. They will not recover directly.
Okay. So do you think that tongue beating in this lady is concerning or no?
No.
Okay. Why not?
But as I said, I need like just someone who witnessed the seizure, just to explain for how long she lost her consciousness.
Okay, do you think that tongue beating can differentiate or can help you differentiating between types of loss of consciousness or no?
It can add, but again, I don't know. Yeah, it most of the time it's with epilepsy, but
okay.
I don't know.
What about TIA? Will you think that this patient may be having TIA instead of seizures or instead of cardiac syncope?
It might be, especially that her diabetes is not controlled.
Okay. So what will you do for this lady?
So I told the lady that I'm going to keep her in the hospital, and I will ask for the routine blood tests, as well as asking for the blood sugar level. I mean the laboratory one, not the capillary. And then I will ask for CT brain as well, to rule out any hemorrhage. And she got the loss of consciousness, so the CT brain might even be helpful to find out if there is any ischemia, like infarct, I mean. And I will also ask for ECG to see if she's having atrial fibrillation, for example, although she denied any palpitations. And I might need to connect her to telemetry, or if she's impatient, or to Holter.
Okay, why you want to admit her, doctor? The last loss of consciousness episode was 1 month ago or more.
1 month ago.
You cannot do these things as an outpatient and then call her back?
I just want to rule out any like I want to check only her bloods, and if the bloods are like if she's not anemic and
thank you very much.
the ECG is normal.
Thank you, Dr. Aziz. You did good, mashallah, very good, excellent. I like your approach, by the way. I felt that you were suffering a little bit. I'm not sure if this is the first time you are sharing with us or no, but let's say something. Doctors who attended with us since we started sharing the videos, we said, please, outside, you will receive a plain paper. I'm repeating this thing every session we meet with each other. Outside in station 4 to 5, you will receive a plain paper outside. It will be like the one you will see on the board now. Oh, just let me open the other program. So you will receive a paper outside. In this paper, you have to write everything. And even you can read from them inside the station if you would like. The examiner will not stop you and he will not tell you what are you doing. He will not do like this. So doctor, please, when you are going to station 2, 4, and 5, please write this outside. Okay. Bismillah. Can you see this? Can you see this now? I'm sharing it. Okay. So come to the point. This is the paper that you receive outside. It will not have lines. It will be plain paper. So you have to divide the paper like this outside, doctor. Why? Because inside, as I told you before, we are studying Pastest for the last few months and maybe for the last 1 year, and many of us candidates didn't pass for the first time. They are stressed. They came from another country. They will meet new people. They don't know anything. Even they will stay in the hotel, and then they will not sleep all the night. And in the morning they will not eat, and they will go. They may be the second or the third carousel. So they will be very stressed. By the end, you will not remember anything to summarize to the patient. So you will divide the paper like this outside, and then here you will write your differential diagnosis. Okay. Here you write the CRB fast and WTS. Here you write the positive data. Here you write the ICE plus management plan. And plus the management plan, you have to ask yourself 2 questions as a physician. What are the 2 questions, doctors who attended with us? What are the 2 questions that you will ask to yourself in any stations you are allowed to talk with the patient in? Can you please write down, doctors, on the chat box, what are the 2 questions that you...
Yes, is this patient need admission, and what about driving?
Yes. Okay, Dr. Said, thank you for sharing. By the way, Dr. Said, please, after finishing this one, just remind me to tell something about the last session, as regard your question. Okay, so you have to ask yourself admission, and does my patient needs admission, and will he need any recommendations about driving or not? This is for yourself. Okay, so come to the points here. What I want you, doctor, in the exam to take this paper with you, or even you can take two pens with you, red pen and black pen, or any 2 colors you would like to have. Inside the station, everything you will finish, you should write tick in front of it. And please, doctor, write the name of the patient here. For example, Mr. Jacob, because inside the station you may find the patient's name, and it will not be nice if you ask his name again. So you have to write his name here again, Jacob, for example. So come to analysis of the things. How to analyze? You can analyze with onset, course, duration, what increase, what decrease, associations, effect of treatment, and date of last attack. This is in analyzing any non-painful complaint. So the onset, when did it start? 2 months ago. course, it will not work here. Duration, lasted for how long? Did you find that there is anything increasing it or decreasing it? Association, is it associated with any weakness, tongue biting, shortness of breath, chest pain, anything? And then treatment. Did you receive any treatment for this or sought medical advice for this problem? No. When was the last attack? Date of last attack. This is very important, doctor. Anything you will find positive here, please write it down here. So my patient had this loss of consciousness 2 times ago. Why you are writing the positive data here, doctor? It's very important because by the end of the session you will forget what you analyzed here. So please write here the positive data, and then to summarize them to the patient again after finishing the stations. Okay, then come to review. Again, doctors, reviewing in the cases does not mean to bring systems from above down. Yes, this is in case of if you forget, but the reviewing of the systems mainly depends on your differential diagnosis. As we said, patient having this loss of consciousness, yes, at this point you can start from above, you can start from the head, and then you can go to the heart, and then to ask about any other thing after this. But it will not be applicable if a patient came to you with joints pain, and then you went and asked him, do you have any headache, do you have any loss of consciousness, and by the middle you asked him about, do you have any skin rash? It's not acceptable, you know. So reviewing of the system depends mainly on the differential diagnosis. After finishing the differential diagnosis, you can review other systems if you want. Come to the past history. The past history, doctors, we said, okay, now I finished, I will write tick like this in the exam, inside the exam, to tell myself that I finished everything. I will write all these things outside. Then come to the P for the past history. SPB, systolic blood pressure, congenital heart disease. This is the mnemonic for the things that you will ask about in the history. S for surgery or procedures. You should have asked this patient if she had surgery or procedures. For example, doctor, this patient may have an implanted ICD or a pacemaker or whatever. Okay, you don't know. You didn't ask about surgery or procedures. Now, second is B, which is blood transfusion, and B, 3 B's for female. Any female ask about 3 B's. Pregnancy period bills. For sure, it is 57, but at least you have to ask her about pregnancy. About this period. Okay, and then C for any chronic diseases. Do you have any chronic diseases that I should worry about? And at this point, don't jump directly to ask him or her about specific disease. What you did, Dr. Razzouz, you told the patient, do you have any chronic diseases like hypertension? So you ask it here about hypertension. He will tell you no, because you asked it only about hypertension. You didn't. You should ask her, do you have any chronic diseases that I should worry about? Yeah, worry about. She will tell you no or yes. Okay. Then she is having here from chronic disease, she is having diabetes. Write down diabetes here. Once you found diabetes, doctor, immediately at the same point you have to ask about diabetic MPH. This is a very common mnemonic. And please, doctor, I will tell you something. One of the colleagues, someone, he didn't reach the diagnosis. He didn't reach the diagnosis, but the patient was having diabetes and a complication of diabetes. He got the full mark despite he didn't reach the diagnosis because he asked about all the things in the diabetes, which is the diabetic MPH. Okay, so D for duration of the diabetes, I for I for insulin. So diabetes duration. For how long you are having this diabetes? I, are you taking insulin? A, what was your last hemoglobin 1C? And then insulin, for sure you will ask about compliance. Okay, then do you have any blurring of vision? Did you check your eyes before? Or are you checking your eyes annually? Do you have any trauma in your leg before? Or have any ulcers or sores in your legs before? No. And then ask him about other complications of diabetes, like heart failure, like renal failure, as she already asked about this. Okay, Ask him here also about any neurological problems, these complications of diabetes, any hypo attacks. Very important. You did not ask about hypo attacks, doctor. Okay, so it should be asked about. So immediately you can ask about this within 20 seconds. And this diabetic MPH will give you the full mark, even if you didn't reach the diagnosis, if your case was a complication of diabetes. Okay, then H4, hospital admission, and G for drugs. And we said, again, drugs for us in the PACES or in our life means three things. You'll ask the patient about drugs. What do we mean by drugs? Any doctor can write or can share. He or she is welcome. Drugs. What do we mean by drugs? Herbal. Excellent. What else? Medications. What is the third one? Illicit. Excellent. So, what do we mean by drugs? Drugs, three things. Medications, illicit drugs, herbal medicine. Medications, illicit drugs, herbal medicine. Okay, next point. Sorry. Okay, so finished tech. Then F, family history. Do you have any family history of similar problem of chronic diseases? No. Do you have any allergy to medication? Do you have any allergy to food? No. Then come to the social history. Social history, mnemonic is sharp J. Sharp J. S for smoking. H for housing. Where do you live and with whom you are living? Okay. Okay. In the smoking, doctors, you ask the patient about how many cigarettes per day, but you did not ask for how long. So please take care about this. Okay, so again down here, my patient is smoker. And smoking index, or you can write smoking index, for example, 20/30 for 30 years, so 60. Here, sorry, we wrote here diabetic, uncontrolled. Plus I, problem. Write these things down inside. You take permission already from the patient. You took permission from him. Then R for recreational drugs, again repeated because we forget it. And then in the session history, B for what and G for what? Any doctors can share, can write. B for what in the session history? Any doctors attended with us? Pets, P-E-T, yes. Pets, and G for job. And job, what do you do for a living? I am retired. What was your job before? This is very important because, for example, the patient came to you with shortness of breath and you didn't not ask him about his job, and you may not reach the diagnosis because, for example, it may be silicosis. Okay, he was working in a shipyard. Then ask about sexual history. Sexual history. This is very important. Very important. And once you ask about sexual history, you should also ask about HIV. And again, doctors, as we said, if I am going to PACES, my case will be HIV or cancer, especially lung cancer, till proven otherwise. This what you will tell yourself when you are going to the exam in the morning, or today or tomorrow. My case is HIV or lung cancer or generally cancer till proven otherwise. They like it so much. Okay, then come to the psychological history. You did not ask the patient about her mood. Very important. Then travel history. You did not ask about travel history. Why we write like this? CRB fast, blah blah blah. Because if you everything you will find, you will finish here. You write tick, and every positive data you write it down here. Okay, because you will summarize to the patient at the end. So at the end, if you heard the examiner telling you 2 minutes remaining, if you didn't ask about the concern, just summarize very rapidly. Okay, Mrs. Jacob, if you allow me to summarize this conversation or this discussion. So you came with loss of consciousness 2 times before. The last one was 1.5 months ago or 1 month ago, and no one saw you. You lost your consciousness completely, and you are diabetic, and your blood sugar is not well controlled, and you are smoking for long period. Is there anything you want me to add? You want to add to me? Is there any problem I forgot to ask about? This is very important, because if there is a hidden symptom you did not ask about, she or me or he may tell you. Okay, then come to the eyes and management. Okay, what's your concern? I'm concerned about this. You didn't answer the patient's concern, doctor. She told you, I'm afraid I may be having this problem. So your answer should be yes or no, or I am not certain. This should be your answer. Okay, I'm so sorry for this, but you know, I'm still suspecting that you may have problem in your brain, or you may have a problem in your heart. Usually, if it is due to bleed, usually bleed does not come like this. But we have to do tests and imaging to your heart, your brain, and we'll take some blood tests for you, and we will hear the things. The patient had loss of consciousness last time 1.5 months ago. Why you are going to admit the patient? At least do basic tests for here, and tell her that you may contact the heart physician today. You may, or as soon as possible, to arrange a meeting for here. To arrange a near meeting with here after finishing this blood tests or investigations. And please, you told me that you are driving. You didn't inform here about driving. I'd like to inform you that it's recommended for you not to drive, because you know, if this issue happened to you while you are driving, your life may be at danger. We are caring about your life, and also I'm sure that you are caring about other people's life. Other people may be affected. If you lost your consciousness while you are driving, you may injure yourself and injure other people. Is it okay with you? Yes, doctor. Do you have any other concern for me? No, thank you, doctor. Yes, doctor, I'm having concern. I want, for example, I want a sick leave today. I want. Okay, this is how to deal with the case. Then come to the differential diagnosis of patient with loss of consciousness. Okay. So loss of consciousness, or dizziness, or dizzy spells, or fainting, all can come at the same approach. Before this session, it may be difficult, but inshallah, after this session, inshallah, it will be very easy. Doctors, can you see this slide now? Can you see the violet color that appeared on the top? If so, just try to me, yes or no. Okay. Okay. No, don't worry, Dr. Azouz. That's why I'm telling you, write the things. So if you wrote the things, you will summarize very good for the patient, and it will help you in reflection, because you will revise your differential diagnosis again. Then, patient came to you with dizziness, dizzy spell, fainting, loss of consciousness, syncope. Here, before going deep into this issue, I'd like to ask what's meant by syncope. What's meant by syncope? Any doctor can share with us. Even you can use the mic. It's open for all. You can unmute yourself and say what's meant by syncope.
Syncope is usually a symptom from the heart, like loss of consciousness, but for few seconds, up to minutes.
Fainting, sorry, syncope is okay. Anyone?
Transit loss of consciousness with self gain again.
Good, excellent. Good. Anyone want to add any other thing? Okay, to save your time.
Reversible. Reversible loss of consciousness.
Reversible loss of consciousness. Okay, so it's please, Dr. I did write it down because the examiner may ask you what's meant by syncope, and if you did not tell him what's meant by syncope, he may take this against you because you know this they consider it as a basics. If you don't know what's meant by syncope, for them it's a bit easy. So syncope is it's a sudden, transient loss of consciousness with inability to maintain the postural tone, with a spontaneous resolution, secondary to decreased cerebral blood flow. So 5 conditions: sudden transient loss of consciousness with inability to maintain the sudden transient loss of consciousness with inability to maintain the postural tone, and with a spontaneous resolution. Okay. Don't say usually from the heart because it may be neurogenic syncope. It may be vasovagal syncope. Okay. And by the way, doctor, I'll tell you something. You know, most of the causes of syncope are not cardiac. Only 15% of the causes of only 15% of the causes of syncope are cardiac. 60% of the syncope, as we will see now, it's called paracardiac. Okay, let's go on. So patient came to you with dizziness or dyspnea or fainting and loss of consciousness, or syncope. You can use the same approach for them. So you have to ask the patient. Sorry, the same as we said. What happened before, what happened during, and what happened after? Before, you were exercising, because if you was exercising and have syncope, you are talking about ultimately cardiac syncope. Ultimately, exercise induced syncope, it's ultimately cardiac syncope, especially obstructive lesions like aortic stenosis, excellent, like HOCM, like pulmonary stenosis. Okay, these are the most common cause of exertional syncope. Plus ischemia. Okay, then positional change. If it changes with positioning, you will think about, I mean, disturbance in consciousness usually, or dizziness or dyspnea. Change in position, it can come with vertigo, for example. Urination, laughing, this happens with, it can happen with vasovagal syncope, chest pain, CB, sorry for chest pain, abnormal smell, abnormal odor, visual hallucinations, blackouts, hunger pains. At least you have to remember 3 or 4 things from this to ask the patient. Because if you ask him what was happening before this, he will tell you like what. Did you feel any abnormal thing? He will tell you like what. So at least mention 2 or 3 things like chest pain, weakness, visual problem, blackout, eye problems, vision problems, blackouts, hunger pains. No. During, anyone told you that you have tongue biting? I'm sorry, did you find yourself wet after finishing? Or you find stool on your underwears after finishing? Anyone told you that you were shaking? He will tell you no. But yes, doctor, I have tongue biting. Yes, tongue biting can add, but it is not diagnostic. And there is something here, doctors. Patients with syncope, yes, they can bite their tongue. They can bite their tongue. But usually they bite the tip of the tongue, and it will be small. But people with seizures, usually they bite the size of the tongue. Okay, and as we said before, biting the tongue is exclusive for syncope or seizures. It cannot be due to psychogenic syncope, for example, someone malingering or this. No, because it's very painful. Try now, doctor, to bite your tongue. You will not be able. Extremely painful. Okay. Then what happened after? As doctor said, did you went into deep sleep, prolonged loss of consciousness? You have any chest pain after this? Any weakness? No, doctor, I did not have anything from this. Come to the core of this session. Patient came to you with disturbed level of consciousness. I want you to ask him one question. Did you lose your consciousness completely? Did you lose your consciousness? Yes or no? If it is yes, is it partial or complete? So remember this small drawing. No, I did not lose my consciousness. The patient was standing, nothing. I didn't lose my consciousness. Okay, so if the patient did not lose his consciousness, so we'll think about CDTV. These are the differential diagnoses of patients came with dizziness, dizzy spell, or whatever. So C for cataplexy, patient had emotion, then sudden loss of the muscle tone. Doctor, please write it down because I will not write it. So C for cataplexy, emotions, then like sudden love, like loving so much, and then he lost his muscle tone. This is called cataplexy. D for drop attacks, which is called atonic seizures, and usually it comes at childhood and stops at adulthood, and it's a very brief, about 15 seconds, 15 seconds, okay? So C for cataplexy, D for drop attacks, and T for TIA. Patients with TIA may not lose their consciousness, they also may lose your consciousness, and they may not lose their consciousness, okay? TIA with carotid origin, they will not lose their consciousness, but for sure they will have some focal neurological affection. Then come to the V, which is vertigo. Vertigo can come as a dizzy spell. By the way, doctors, vertigo came a case in the last diet, but I cannot remember in which country, but it came. I think India. Okay, so vertigo. How will you ask about vertigo? Do you notice that the room is spinning around you, or do you feel that this dizziness or this spell or this abnormal sensation comes to you when you are moving your head from side to side, or you find it while you are turning in the bed right and left? All this can happen with this vertigo, doctors. Then come to the causes of vertigo. Dumbbell, you know dumbbell? Please, doctors, write this down. Dumbbell, D-A-M-M-B-L. Drugs, acoustic neuroma, multiple sclerosis, migraine, Meniere's disease, fullness in the air with tinnitus, benign paroxysmal positional vertigo. This is what happens when he changes his position. Labyrinthitis, patient with dizziness, sometimes with vomiting and fever, and usually treatment is conservative because it's a viral infection. Okay. Then come to the next. So if he did not lose his consciousness, think about CDTV. Okay. Then come, yes, I lost my consciousness. So the second question, is it partial loss of consciousness or complete loss of consciousness? He will ask you, what do you mean by partial loss of consciousness, doctor? I mean, did you feel that you are dizzy? I mean, you are hearing the people around you, but you feel that you cannot respond to them? This is what's called by partial loss of consciousness. But complete loss of consciousness, he couldn't hear anyone, and he cannot even remember what happened, what the events that was happening inside. So there is a differential diagnosis. If the patient had partial loss of consciousness, we are having a differential diagnosis here, which may be low blood pressure. So see, I put this one to just remind you, partial loss of consciousness. He is on the ground, but he can hear the people. This is called partial loss of consciousness. Okay, so low blood pressure. Before low blood pressure, doctors, I would like you to write low temperature. Low temperature, it's important, okay? Low temperature, low heart rate, and disturbed level of consciousness a little bit. What will you think? Which disease is this, doctors? You can write or even talk. Which disease will cause this issue? Patient with, sorry?
Hypopituitarism, maybe?
Hypothyroidism, yes.
Hypothyroidism.
Yes. Low blood pressure, sorry, low temperature, low heart rate. Think about myxedema coma. Okay. So before low blood pressure, I just want you to write low temperature. Then come to the low blood pressure. The patient may have loss of consciousness because if he is having low blood pressure, orthostatic hypotension, you feel dizzy when you stand up from sitting position or no? This is called orthostatic hypotension. The most common cause of orthostatic hypotension is drug induced. This is the most common cause. Okay, so you know the Hanadi, huh? It's a name of a girl, Hanadi. These are the causes of low blood pressure, I mean orthostatic hypotension. H for hypovolemia, okay, N for neuropathy, whether primary neuropathy like Parkinsonism or multiple system atrophy, and or secondary like diabetes or amyloidosis. This is secondary autonomic neuropathy. They cause orthostatic hypotension. A for sure Addison disease or adrenal insufficiency generally. And then drugs, the most common cause, like diuretics, vasodilators, alpha blockers, L-DOPA. Any male came to you with history of benign prostatic hyperplasia, and he came with orthostatic dizziness or orthostatic hypotension. This is mostly a drug induced because the alpha blocker they are using in the BBH, they can cause dizziness. I want you to ask any old patient in your clinic, doctor, within the next few days when he comes to you, if he is receiving any treatment for BBH, you'll find that he is having, they may have orthostatic hypotension. Okay, and then L-DOPA, by the way, which is used in Parkinsonism. So Parkinsonism itself can cause orthostatic hypotension, and his medication, which is L-DOPA, also can cause orthostatic hypotension. The next is the low blood sugar. So we said low temperature, low blood pressure, and low blood sugar. The causes of low blood sugar. Common mnemonic is re-explain, but it's heavy. Now we are learning how to get the causes from the name of the disease itself. So the low blood sugar is sugar, the causes are sugar. Please write this down, doctor. S for sepsis. If the patient is having sepsis, he will have low blood sugar. If he is having up insulin, I mean high insulin, if he is receiving high dose of insulin or anti-diabetic drugs, or if he is having hyperinsulinoma, okay, this is up insulin. G for GI problem. Patient have GI bypass or resection, like in patients with inflammatory bowel disease, and they are having resection, they may have low blood sugar. And A, alcohol, important, and Addison disease, okay, and hypopituitarism for sure, and hypopituitarism. So A, alcohol, Addison disease, and here also we will add anterior hypopituitarism mainly. Then R for renal failure and liver cell failure. These are the causes of low blood sugar only that can cause this one. So a patient lost his partial loss of his consciousness. Ask him about orthostatic hypotension. No, then ask him about manifestations of low blood sugar, like shivering, like hunger pains, like sweating, like racing of heartbeats. These are the manifestations. If he is having both, so think about Addison disease, or not Addison, I mean the adrenal insufficiency. The causes are the Addis. What are the Addis? They T for TB or thrombosis, and then you will ask about 6 questions of blood clot. And now I think that you know them doctors who attended with us before. H for hemorrhage, 4 questions for hemorrhage, and E for endocrine, pan hypopituitarism, and A for amyloidosis. Okay, and D for drugs like ketoconazole, rifampicin, barbiturates. They can cause adrenal insufficiency. Infection. If I am going to the basis, my case is HIV or cancer, terproven otherwise HIV. Okay. Steroid withdrawal. It's at the end, but this is the most common cause of adrenal insufficiency. The steroid withdrawal. Okay. So now patient came to you with complete loss of consciousness. No, doctor, I lost my consciousness completely. So the next question here, can you please tell me, is it your consciousness with a short period or long period, because the differential diagnosis is different in between them. See, I put this gentleman lying flat, lost his consciousness completely. Okay, short period or long period. If it is short period, think about cardiac, paracardiac, or neurocauses. If it is longer period, think about seizures, and please add here also coma. Sorry, I did not add coma. You can add it also besides seizures. Okay, doctors. So now, what are the cardiac, paracardiac, and neuro? Paracardiac, this is just to remind you. There is nothing called the paracardiac, by the way, but I just put it to remind yourself. And this is the most common cause of syncope. The paracardiac, about 60% vasovagal syncope, carotid hypersensitivity syndrome, and subclavian steal phenomenon. This is a paracardiac. This is the most common, and the most common between them is the vasovagal syncope. Okay. Then come to the cardiac. The cardiac, only 15% of causes of syncope are cardiac, like arrhythmia, ischemia, or malfunctioning of a pacemaker, or yes, malfunction with a pacemaker. So arrhythmia, ischemia, or malfunction of a pacemaker. The patient pacemaker dependent, and now the pacemaker is not working well with him. This patient, you have to admit him. Okay, imagine Dr. Aziz, if this patient had a pacemaker and you forget to ask him about a previous procedure. Okay, and the good thing, you told him you will be admitted, but you didn't. If you ask it about the procedure, he may told you, by the way, you were in the correct way and you get nearly the right diagnosis. But now I think it will be more easy for you to pick up the diagnosis very rapidly. And the patient with a malfunctioning pacemaker should be admitted. And the admission does not mean to admit him inside the hospital for 1 or 2 days. Just if you have the, you can tell with here, I will arrange an urgent meeting to you today. If it is available to do interrogation, I mean, check your device today. And if you find it okay, we can discharge you safely. And if anything abnormal, we will admit you. If we couldn't arrange this, we will admit you. For sure, we will contact the cardiologist, heart physician. Okay, then come to the neuro. It may be TIA in the vertebro-basilar artery. Okay, doctor who is having noise, please. Dr. Akirit, yes. Okay, so patient with vertebro-basilar will have loss of consciousness, but as we said before, in the carotid region, he will not have TIA, the CDTV. This one will not have loss of consciousness. I mean, it will not be complete loss of consciousness, and no loss of consciousness, just neurological affection and some disease spell. But here, the patient who will have TIA at the vertebro-basilar, he will have loss of consciousness. So not all TIAs cause loss of consciousness. Okay, syncope can come here. Sorry, stroke can come here and can come here. So it can come short. It can cause short time loss of consciousness or even long period. So long period, think about seizures, coma. Okay, what are the causes of coma? You know, doctor, 40% of the causes of coma in UK are secondary to drug overuse. Medications generally. Okay, like serotonin, amphetamine, anything from this. This is the most common cause of drug-induced coma there. Okay, others secondary to prolonged cardiac arrest or low blood sugar. I mean glycemic coma, hypoglycemic coma, not just low blood pressure causing dizziness, hypo attack. No, this is a hypoglycemic coma. Okay. Then come to the seizures. What are the causes of seizures? It's very easy, doctor. As we learned it before in the medical schools, now the cause of seizures, either epilepsy or other things, trauma, tumor, infection, vascular, metabolic drugs, trauma, head trauma. Don't forget, patient with fluctuating conscious level, think about what, write Dr. please on the chat box or say it by voice. Fluctuating conscious level. This is very important here. Patient with fluctuating consciousness level. I mean, he lost his consciousness. Then again, subdural hemorrhage. Yes, yes, subdural hemorrhage. You have to ask about trauma and alcohol. Then tumor, patient having expanding tumor or infection. You should ask about fever, neck stiffness. Okay. Vascular. Ask about any the 4 questions of bleeding and 6 questions of thrombosis. Metabolic encephalopathy, hepatic encephalopathy, hypertensive encephalopathy, uremic encephalopathy, or electrolyte disturbance. And finally, drugs, as we said, cocaine and ecstasy, and this is the most common cause. No, this is the most common cause in coma, not in epilepsy, in seizures generally. Okay. Now, doctors, it's very easy, inshallah, to reach the diagnosis very early. Sir, sorry, did you lose your consciousness? No. Imagine that this was your case in the last time. Did you lose your consciousness? No. Then you will ask about CCTV. Can you tell me, did you lose your consciousness? Did you you were doing something like laughing before losing your consciousness? No. For sure, it will not be an atonic seizure. By the way, it will not be a drop attack. This is a 57-year-old, so no need to ask about this. Okay. V. Did you feel that the room is spinning around you? Yes, doctor. This is your case. So, doctor, in the first minute, you can reach the diagnosis immediately. If you went with the mind map, you will reach the diagnosis immediately. Or did you lose your consciousness partially? No. Completely? Yes. For a long period or for a short period? No, doctor. It was for a short period. I don't know, doctor. He doesn't know, but he was in the street, you know, in the street, and spontaneous resolution, and with minimal events, no drama happened, no tongue biting, no weakness, no deep sleep, no wetting of his clothes, no defecation. So this is non-cardiac. Sorry, this is not in this arm. It will be short period, so it may be cardiac or paracardiac. One of these things. So you can reach the diagnosis very early in the first minute if you want with this mind map. This mind map you will write outside the station before entering, and look at this mind map inside the station. Okay, doctors. These are the things that we said. Oh, sorry, I wrote. Okay, very good. So I will make it here so that you can, if it is recorded now, so you can know what is happening. Sorry, this is hemorrhage. Sorry, this is by mistake because the autocorrection in the PowerPoint. This is not 62. So this is TB or thrombosis. 6 questions, not 62. And this is hemorrhage, HGE. 4 questions. Okay, doctors? And this is HIV. I'm so sorry because I have no time to correct these things. Okay. And we talked about complete loss of consciousness, the good thing. I'm just sharing. You can look at the video after we finish. Okay, doctor. So these are the things, the causes of loss of consciousness, disease or disability. Do you have any other question, doctors? Because we have to move to the next step. Next case. Move to case. Any questions? Any concern? All the problem most of the time about this, I don't know. All the problem most of the time about this, I couldn't get you. Thank you, doctor. Okay. So with the mind map, inshallah, you will reach very easily and very early. Any questions, doctor, for this point? We have to move to the next case. Okay. Dr. Syed, you are with us, Dr. Syed? Dr. Syed with us? Okay, anyhow, in the previous session, doctor, when we talk about the headache and the approach to the headache, it come one of our dear colleagues, I'm not sure, sorry, I cannot remember. Okay, doctor, don't worry, I will share it by the end of the session, inshallah. Or any of our colleagues can do favor for us, please, and share the link of the WhatsApp or the link of the YouTube on the chat box. So, doctors, please. In the last session of headache, one of our dear colleagues said that he had a case patient came with headache for the last 2 weeks, and then and the headache, the nature of the headache was throbbing, and we said it may be migraine or it may be subarachnoid hemorrhage. But we forgot to say another important third thing. Yes, doctors, I researched again, I searched again about this to make sure that I didn't deliver you wrong information. Yes, doctor, throbbing pain is one of 3 causes, either migraine, subarachnoid hemorrhage, or an expanding lesion in the brain, like tumor expanding in size or an abscess. Okay? So yes, subarachnoid hemorrhage also can come with chronic headache. I mean, headache can come, it can come, usually it comes as thunderclap headache, but it can come, it can last hours, days, and sometimes weeks. It can come patient having headache for the last 2 weeks, because you know it depends on the size of the blood vessel which bleeded. And the third, if it is very small and narrow, and then bleeding very minor amounts of blood, subarachnoid hemorrhage, he will not have that severe thunderclap headache. Okay, and the third one, as we said, expanding lesion in the brain like tumor or an abscess. Okay, next case, doctors, will be station 5. I will take station 5. I will just share the channels for you, doctor. Give me a few seconds. Any doctor wants to take the station 5, just raise your hand or say, doctor. Okay, doctors, who asked about the channel? This is everyone in the meeting. These are the links. These are the links. Okay, Dr. Hanan. So you will take the next case, Dr. Hanan. Okay?
Yes, sir.
Okay. This is your case, Dr. Hanan. Read it. Station 5. And then we will start after this. okay? Dr. Hanan, can you start?
Yes, Doctor.
Yeah, okay. Can we start, Dr. Hanan?
Good evening.
Yes, good evening.
I am Dr. Hanan, one of the medical doctors today. I want to confirm that you are Mrs. Ren, 47 years old,
Yes.
right?
Yes. That's it.
Mrs. Ren, you have been trouble with hand problem. Can you tell me more?
Yes, doctor. For the last 6 months, I couldn't grab things well with my hand. I don't know what's going wrong with me.
Okay, I am sorry for that. Do you feel that your hand is weak? You cannot take any object?
Yes, doctor. It's weak for the last 6 months, as I told you.
Okay. Which hand? Both hand or one hand?
Both hands, doctor. It's annoying me so much.
Right. Is it any numbness in the hands?
Numbness?
Mm.
No.
No numbness. Okay. This weakness only in the hand or involving the arm also and shoulders?
No, doctor. It's in the hands.
In the hands. Okay. Any pain in the hands? Yes.
No, doctor. I don't have pain in my hands.
Only the weakness.
Yes, the weakness.
Okay. Is it started suddenly?
No, doctor. It's not suddenly for sure. It's for the last 6 months.
6 months and now progressing?
Sorry?
Seem to be progressive now?
Progressive? Yes, doctor. Progressive.
Uh-huh. Right. Is it affecting your ability to wearing clothes and removing the clothes and doing some daily activities?
So much, doctor. Now, so much.
Okay. Right. Do you have any neck pain?
No, I don't have.
Right. Okay. Any back pain?
Back pain? No.
Okay. Can you tell me about your past history? Do you have any chronic illness before?
Chronic illness? Never, doctor. I was completely well till the last 6 months. Also, I found my shoulder is not the same shape.
That's before. Uh-huh. Any shaking in the hands?
No.
No shaking. Any hotness in the hands or anywhere in your body? Increase in the body temperature?
No.
So do you have any joint problem before?
This is station 5, doctor. Do you want to examine me before the time runs out?
Yes, I want to check for the.
I'm kind of survey. Okay.
I want to check the movement of the hands.
That's me, doctor.
So,
I'm on the screen. I'm on the screen now. You can look at me if you want to do anything with me.
okay, right, doctor.
Okay.
This is.
Yes,
Yeah.
this is my hands.
I want to check for the reflexes in the hand and the elbow reflex.
Elbow reflex. Okay. Normal.
Brachioradialis reflex. Normal reflex. And the tone?
Normal.
Normal tone. Okay.
Yes.
Cerebellar sign? Any cerebellar sign in the hand?
Sorry?
Last pointing.
What?
Cerebellar sign.
What is this? Cerebellar sign. You are examining now. You are not asking about anything. No, doctor. No cerebellar signs.
No cerebellar sign.
No
okay, right.
post pointing or anything. Yes.
Checking the eyes for eye movement.
This is my eye in front of you, doctor. You want to examine the eye movements?
Yes.
No abnormality in the eye movement.
Any dropping of the eyelid?
This is my eye. You can have a look. Doctor, who wrote the diagnosis on the chat box? I think this is not, you know, no need to write such things. This is a private. Let's finish. Sorry, doctors, because I just.
Yeah.
Okay, doctor, you can go on.
Yes,
Tell me.
doctor.
Yes,
I want to look to the neck for any scar in the neck.
no scar. This is my neck in front of you, doctor.
Okay, right. Just I want to auscultate the heart and to check the basal.
Auscultate the heart. Okay.
Okay, I want to ask
Nothing in the
about.
heart.
Okay, right. Job, about the job. What you are doing for a living?
I'm retired. I was driver in a company, but I'm retired now.
Okay. We need help regarding your life issue, but we will help you by referring you to a social worker. Do you smoke?
Yes, doctor, I'm smoking, yes.
How many cigarettes per day and for how long?
20 cigarettes per day for the last 25 years.
Okay, Mrs. If you do not mind, we can I advise you to stop smoking by referring you to the smoking cessation clinic. Is it okay for you?
Okay, doctor. Thank you very much.
Okay. Are you driving now?
1 minute remaining. Sorry?
You are driving?
Yes, doctor, I'm driving.
Is it difficult for you by the weakness of the hands?
It's not that difficult, but I can manage. Still, I can manage.
I advise you to stop driving till we reach the diagnosis and to solve your problem, if you do not mind, because it can make a problem for you.
Why, doctor, stop driving? I'm driving well. I have no problem.
Because you said you have a weakness in the hands.
But I can manage driving, doctor. Okay. I'll think about it.
Okay. What is your concern?
I'm concerned about this the weakness of my hand, doctor, and the shape of my shoulder. You know, you can find my fingers are not mine. What's gone wrong?
Okay. After examining you and this history, you most probably having a problem.
Time. Thank you. Okay. So, what's your different? What did you find in this patient, doctor?
She having a wasting of the small muscle of the hands.
Be talkative, doctor, please. Be talkative. Eh? When the patient, when the examiner asks you something, keep talking. Don't stop. Keep talking. Don't stop. Unless he stopped you. Okay. So, what did you find in this patient?
Just the finding that she having wasting of the small muscle of the hand with normal tone, normal reflexes, maybe most probably due to the muscle problem. With
So,
positive
proximal myopathy. Did you examine the hand of the patient well? Did you examine the ulnar nerve, median nerve, radial nerve?
Just I want to check for all. But you said to me, look to the picture only.
No, I'm waiting you to tell me.
Neurologically.
I want to examine 1, 2, 3. Okay.
Yeah, I will check the sensation in the ulnar side and the median nerve side, and I will check.
You didn't examine this. Why? It should be examined. Okay. Anyhow, so what's your differential diagnosis?
This is could be due to peripheral neuropathy.
Peripheral neuropathy. Without sense, did you check for sensation to say that this is a peripheral neuropathy?
She said she have no numbness, no loss of sensation.
So why do you think that this is a peripheral neuropathy? You mean
Yeah,
motor
mostly
neuropathy only?
motor. Yeah, like this, I think. Then I think about the motor neuron disease, maybe, and I think about the cervical myelopathy also.
What else is cervical myelopathy? Okay.
Yes.
So what will you find in a patient with cervical myelopathy?
But again, is this the reflex is the no impairing the reflex, no inverted reflex.
What will you
actually.
find in the cervical myelopathy? This is a problem. When you say something wrong, he will forget everything. He will forget his name and then ask you, what did you find? What will you find in this?
In the cervical myelopathy?
Yeah.
In cervical myelopathy, we will find the wasting of the small muscle of the hand with the sign of feature of upper and lower motor neuron.
And what
with
else?
Inverted reflexes of the hands.
Inverted supinator reflex, pseudoathetosis
Yes.
as well. Okay. Okay, doctor. So what else did you find in this patient? Okay.
The picture in the neck not clear for me, doctor. Only I observed the hyperpigmentation in the neck. I couldn't see.
Time.
Good.
It's okay. Thank you very much for sharing with us, Dr. Hanan. You know, you did well, but I think with this approach, inshallah, it will be very easy after this. After we see how will we approach a patient with wasting of the small muscles of the hand, it will be easy. By the way, this is not hyperpigmentation. This patient, this is a color. This is a burn from the sun. You know, it looks like a burn from the sun. Okay. So initially, what did we found this patient? This patient's having wasting of the small muscles of the hand. See, there is flattening here of the thenar. It's the hypothenar is not cannot be well seen. The second thing, this patient is having ptosis here in the right eye. You did not comment on ptosis at all. This patient also is having Charcot joint in the left shoulder. See, and even he mentioned to you that the shoulder is problematic for him. So this is a Charcot joint in the left. Distorted, distended, and distracted. Seems to be distracted. Okay. Okay. So this is a station 5. You have to take detailed history, and you have to examine also specifically something. So how to reach the diagnosis of a patient came to you with wasting of the small muscles of the hand. You can see the screen now, doctors. Now it's full screen. Should be full screen. Now you can see the full screen now. Just please tell me, because when I'm putting full screen, you will not see the things. You can see the full screen, doctors? Now you saw the gentleman appearing, huh? Okay, so you can see the word thinner now?
Yes.
Okay, that's good. So patient came to you with a hand problem, and this what was written outside. Here you will have a problem because you don't know what is the problem exactly. Is it wasting of small muscles of the hand, or your problem will be carpal tunnel syndrome, or it will be a Raynaud's, or it will be an osteoarthritis, and you will follow different maps. So you have to write things very rapidly. You know, if it came to you with a hand problem outside, then patient came with thinner eminence affection. This is called ape hand. You know, it's one of the monkeys. Ape hand. See, this is the ape hand, doctor. The thumb will be adducted, and there is inability to extend flex it. Okay, so think about and lost opposition. Sorry, this is the which nerve doctors can cause this problem? You can write me. For sure, no.
Median nerve.
Sorry, doctor said ulnar nerve. Yes, median nerve. No.
Ulnar.
It's ulnar. Sorry. So so if there is affection of the thenar eminence, sorry doctors, I got confused. I'm so sorry. Patient came with ape hand. This is a median nerve. So the ulna is medial. The ulna, the bone itself is medial. So affection in the thumb, for sure, it will not be the ulnar nerve. It's the median nerve. So it will be, the thumb will be in adduction and lost of position. I will have a session, inshallah, but not now, maybe in the next month, about the movements of the hand and how to examine the hand, because you know it's very, if it came to in the exam and we couldn't examine well, it will not be good. So patient came with ape hand. Look at the patient's hand. If it is ape hand, you got the diagnosis. This is a median nerve. If you found a claw hand, it's either one of two things. Either it is partial claw hand or it is complete claw hand. If it is wasting of the hypothenar, as you see here, so this is an ulnar nerve affection. And the ulnar nerve affection may be, as we said, partial claw hand or complete claw hand. Partial claw hand, here the affection will be at the elbow. If it is here, it will give a complete claw hand, and this is called ulnar paradox, because you know usually you suspect that if the things are proximal, more proximal, the lesion will be more severe. But here the paradox, here the lesion is proximal and the affection is less. So the lesion here at the elbow. What is the most common cause of this? The patients with supracondylar fracture, or people who are resting on their elbow long times, like people who are writing on computers or whatever. Okay, so if he is having wasting of both thenar and hypothenar, or even sometimes one of them, I want you to follow this algorithm, doctor, or this mind map. It will be very easy to, inshallah, to reach the diagnosis. Patient came with wasting of the small muscles of the hand. Hello, how are you? I'm Dr. Hanan, one of the medical doctors on the clinic. You are talking to the patient and looking to his face. If you found your patient is having ptosis, while you are talking at his face, you got the diagnosis. You can reach the diagnosis from the door while you are entering. Just looking at the face of the patient, if the face of the patient is having ptosis, you got the diagnosis. Because it will be one of three, no more. Syringomyelia, cervical rib, Bank's tumor. Because these three things causes Horner syndrome. So patient came with the small muscles of the hand, wasting of the small muscles of the hand, and ptosis, I mean Horner syndrome, you got the diagnosis, and it will be a gift for you in the exam. You will reach it very easily. It can come to you as a station 5 or a long case in station 3, by the way. So this algorithm is valid in both of them. So look at the face. If you found ptosis, so think about syringomyelia, cervical rib, Bank's tumor. Okay. No ptosis. Here, by the way, you have to look at the neck. You may find scar and ask the examiner that, say, I'd like to listen to the chest. If you told him that you want to listen to the chest, so he will know that you nearly reached the diagnosis. So wasting of small muscles of the hand is a gift, doctor. Look at his face. Ptosis, one of these three things. Syringomyelia is very easy to reach, because if you looked at the hand of this patient, as we will see, you will find some things that are characteristic for this. No ptosis. So no ptosis, look at the axilla or the neck. If you found any neck scar, look at the axilla on the neck scar. Sorry, oh, sorry, doctors. This is my mistake, but I didn't have time to correct this. It should be up here, because you should search for also any scar in the axilla or the neck to search for cervical Bank's tumor. So please, just if you are taking screen capture for this, just please remove this no and put it down. Okay, nothing of this is a scar. Okay, nothing from this or this. Look at the back of the patient. If you found kyphosis, syringomyelia. Because not all cases of syringomyelia can cause ptosis, because we will see the effect of syringomyelia now. So if he's having kyphosis or sometimes scoliosis, so think about syringomania. Okay, nothing from this. So go to the upper limb. Upper limb, you are having a hand. Patients with syringomania, what is the characteristic sensory defect in patients with syringomania, doctors? Can you share with me, please, with us? Patient with syringomania, what is the characteristic change? Can you write or can you talk?
Dissociated sensory loss.
Very good. Dissociated sensory loss. What's meant by dissociated sensory loss? What's meant by dissociated sensory loss? Okay, I will tell you in the next, I will write and I will tell you what's meant by this. But this patient will not feel pain and will not feel temperature. So one person cannot feel pain, prick, or temperature. What you imagine, you will find multiple scars because he cannot feel pain. And for sure, multiple burns in his hand or in his forearm because he cannot feel any pain or burns. So you may find burn, scar, reduced pain, prick, syringomyelia. So you have to examine his the sensory system of this patient. Then simply it may be a rheumatoid arthritis causing wasting, disuse atrophy. Patient with rheumatoid hand cannot flex his hand, so the muscles will be atrophied because he is not using them. It may be also combined ulnar and median nerve, combined median causing thenar eminence affection, and ulnar causing hypothenar eminence affection. Or finally, look at the lower limbs, doctor. If you found that his lower limbs are floppy, you are talking about hereditary sensory motor neuropathy, Charcot-Marie-Tooth syndrome. If you found that your patient is having combined upper and lower motor neuron lesion, you are talking about one of two things, either syringomyelia or amyotrophic lateral sclerosis. These are the causes of wasting of the small muscles of the hand. Very easy approach. You will reach the diagnosis very early, and I'm sure that the examiner will be impressed. Because, hello, how are you? I am Dr. Hanan, one of the medical doctors in the clinic. I hear that you are having problem in your hand. Can you please tell me more about your condition? Yes, doctor. I started to have problem in grabbing things for the last few months. I'm sorry for this. Can I examine you while you are and can I? He is telling you, and you are looking at his eyes, and now you got the diagnosis while he is talking. He's having ptosis. So he's having ptosis. So my differential diagnosis is one of three. Syringomyelia, cervical rib, pancreatic tumor. Nothing? Okay, can I have a look at your neck before? Did you have any scar before? No. Can I have a look at your back? No kyphosis. Okay, can you show me your hand? Yes, just complete please what was happening. Okay. And you are examining his hand for being a rheumatoid hand or no? Okay, I'm going to check the sensations in your hand, and you then start to check the sensation in his hand for the median ulnar and radial nerve distribution, and also the movements of this. And inshallah, we may have a session if I have time to make it. Okay, so it's very easy. Ptosis, wasting the small muscles of the hand, one of these three things. Nothing from this, go down to the upper limb. If you found these things, pain, scars, think about syringomyelia. And it may be combined upper traumatic. You should also search for any scar. It may be a trauma, for example. And if doctors who will attend with Dr. Majdi or Dr. Ramadan in Egypt, there is one nice guy, very nice guy, having problem in his hand. I will not tell you what it is, but he is having some nerve affection. Then go to the lower limb and examine, as we said. Lower motor neuron lesion, I mean floppy with biscavus and inverted champagny pottle in the thigh, and there is hypertrophied nerve. Think about hereditary sensory motor neuropathy, Charcot-Marie-Tooth. Finally, combined upper and lower motor neuron lesions, syringomyelia, amyotrophic lateral sclerosis. So, what's meant by syringomyelia or the surnix? It's a case.
How about
yes?
How about subacute combined degeneration of spinal cord can be added here in lower limb?
Subacute combined degeneration of the cord. It can cause posterior column affection, and it can cause peripheral neuropathy. It can cause peripheral neuropathy. But causing wasting of the small muscles of the hand, I don't know. I will not say I don't think, I don't know. But what I know, it can cause posterior column affection and peripheral neuropathy. And peripheral neuropathy, disturbed sensations, it will be disturbed sensation, but twisting in peripheral neuropathy, usually it's one of the two things. Either it is from the start, like hereditary sensory motor neuropathy, or delayed if it is acquired, like in diabetes, for example, or in tabes dorsales. I thought that you are asking about tabes dorsales. However, subacute combined degeneration, also posterior column, and this peripheral neuropathy, and you can find also upper motor neuron lesion in them, in the patients with subacute combined degeneration, upper motor neuron lesion. But wasting, I don't know also if it is causing wasting. Do you know that it can cause wasting or no? But it's not in the causes of wasting. That's what I am sure. If you read it at any place, Dr. Said, just please let us know. Okay. So what is Cernix? Cernix in the syringomyelia, it's a case filled with CSF. So the case filled with CSF, usually it comes in the cervical region of the spinal cord. So it can go up or go down, go up and affecting the brainstem, or go backwards a little bit and making a compression on the cerebellum, and it can extend it down to the spinal cord. So if it is extended up to the brainstem, it can affect the medulla oblongata, from 9 to 12, causing bulbar palsy, lower motor neuron lesion, or it can extend backwards to the cerebellum, causing cerebellar manifestations, or it can go down to the spinal cord, and even it can compress the sympathetic chain, causing a Horner. And very importantly, also it can compress the pyramidal tract, causing upper motor neuron lesion, spastic paraparesis. So it's a case filled with CSF. It can affect the pyramidal tract, compressing it, causing spastic paraparesis. It can affect the cerebellum, can affect the brainstem. Yes, by the way, it can affect the fifth cranial nerve, because doctors, the nucleus of the fifth cranial nerve, the sensory nucleus of the trigeminal nerve, is down. It's in the medulla oblongata or in the lower part of the bones. I cannot remember actually, but the Cernix can compress it, causing sensory dissociation. What's meant by sensory dissociation? He will lose the pain and temperature, and it can affect the bulbar nerves. Ask the patient to open his mouth, say ah, move tongue from side to side. You are checking for the bulbar muscles, okay? But for sure, I'm not sure if it came before in the exam or not. And the spinal cord, and said mainly cervical, and finally sympathetic chain, Horner, and Charcot joint in the elbow, as we saw this gentleman's picture. Okay, so this is another approach for wasting of the small muscles of the hand, or this may be questions from the examiner, by the way. The patient, the brachial plexus may be compressed, brachial plexus from C5 to T1. It can be affected in the cervical rib or pancreas tumor. Anterior horn cells of the C8 to T1, syringomyelia, hereditary sensory motor neuropathy, or motor neuron disease. Nerves from C5 to T1 combined, median, because the median takes, yes, the median takes from two cords, the ventral and the medial cords from the brachial plexus, and so it's from C5 to T8 actually, to T1, because the first cord is, I think, from C5 to C8, and the second from C8 to T1, and finally the ulnar nerve. So see, mainly the anterior horn cells of the C8 T1 affection. T1 should be affected to have wasting of the small muscles of the hand, and finally rheumatoid arthritis. Okay, doctors, is it clear now how to reach the diagnosis of patient with wasting of the small muscles of the hand? Very easily. Yes, inshallah, I think it will be easy. I will share this because I have to say something about the. I have to say something about. I'm not good in drawing, So please forgive me. Okay. If this is the cord, doctors, here the anterior spinothalamic tract. The anterior spinothalamic tract. This is responsible for the touch. Here, lateral spinothalamic tract. Lateral spinothalamic tract. This is responsible for pain and temperature. Okay. What happens in patients with syringomyelia is that the cervix will be here. So usually also the pyramidal tract is here. So it can compress the lateral spinothalamic tract, but not the anterior spinothalamic tract. And also, by the way, it can affect the pyramidal tract. So if it affected the lateral spinothalamic tract, it will affect pain and temperature, and it will not affect this one. So it will not lead to loss of touch. So syringomyelia, syringe, you know syringe, okay? And please, I am not good in drawing. This is the third time I say it. Syringe, cause pain. This patient will not feel any pain. And this patient will not feel any temperature. He cannot feel any pain, so you'll find multiple scars in his hand. Because he cannot feel pain. Cannot feel temperature, you'll find multiple burns in his hand. Okay, doctors, this is clear now? Okay. Okay, any questions till now? Is it clear? Any questions? Okay, again, Dr. Said, you said subacute combined degeneration of the cord. Subacute combined degeneration of the cord. Subacute combined degeneration of the cord, it will affect the posterior column. It may affect the pyramidal tract, and also it can cause peripheral neuropathy. Peripheral neuropathy means nerve went out, actually, from here. So the patient to have wasting of the small muscles of the hand, the problem may be local or due to anterior horn cell affection, mainly T1 as we saw, or a local problem like median nerve affection in a mononeuritis multiplex or mononeuropathy, or the third is rheumatoid arthritis. So I don't think that subacute, I didn't read that subacute combined degeneration can cause this problem. Okay, doctors, is it okay with you now? Any questions? Dr. Arana says superficial sensation is lost. Not all superficial sensations. Mostly not all superficial sensations, mainly pain and temperature. Yes, we see disuse atrophy in the rheumatoid arthritis, for example. Okay. Okay. How about surgical third nerve palsy? Surgical third nerve palsy, but surgical third nerve palsy will not cause wasting of the small muscles of the hand. Oh, sorry, there are lots of comments here, but I didn't read them. Median ape hand, okay. Okay, doctors. Any other question, any other comment till now? Okay. Sorry. Can I ask you, doctors, just to stop here, because since yesterday 1 p.m. sorry 1 a.m. I slept only 2 hours. So if you would allow me to stop here, and we may continue, inshallah, if I have time recently. Okay, doctors.
Highly appreciate, Doctor. Very nice. Thank you.
Thank you very much, doctors. Happy to meet you today. You can share with us on the WhatsApp group and the Telegram and the YouTube channel. You will find the previous sessions, inshallah. Thank you very much. Assalamu alaikum.